First off, thank you very much for having me here today to speak. It's an honor to be among such esteemed company. I want to start today by taking you through a narrative that I hope will resonate well with the audience here. So let's pretend I am your patient. It can be a rural area of India, it can be an urban area of India, but I don't always have good access to healthcare. I have few means, and traveling to a medical facility for me is not trivial. That it takes a lot of effort to get me motivated and to get there in the first place. And most importantly, I'm sick. The malady doesn't necessarily matter as much as just the point that I have few means and I'm sick. So I visit you for treatment, and I've seen a lot of examples today of phenomenal treatment facilities and the ability to deliver wonderful care. So I receive good treatment at your facility. So now I need a follow-up. So I've got an ailment that requires me to come back in a couple weeks or a couple months to continue to get good care. And I go home. And in a lot of situations, what happens next? If I don't come back for that follow-up visit in a couple weeks or in a couple months, who knows what could happen? I could have gotten better because the medicine you prescribed worked. I could still have the same ailment because nothing happened, or I mean, at the worst outset, I could be dead. And the systems don't follow that. Nobody really knows what happened in that scenario. We call it a kind of a lost follow-up case. So there's a lot of different ways to kind of address that lost to follow-up case. And in this narrative is a very specific example of kind of a one problem that within healthcare, and one area which electronic healthcare has the possibility to kind of make a big difference. And an example that I'll talk about has a lot to do with the work we do in rural areas, so with ASHAs and Anganwadi workers for the NHRM. The ASHA program through the NHRM is an amazing program, employing 750,000 different ASHAs since 2005. Some of those ASHAs do their job really, really well. It's unbelievable what they're able to do. Some of them aren't able to do as well. So across that 750,000, you've got a broad spectrum of capabilities of what they can do. The potential for what they're able to do is enormous. They're all trained in techniques with proven healthcare potential to dramatically improve maternal and child healthcare. But it's proven potential based on the protocols that they're given, and it only will result in improvement if they're able to adhere to those protocols and adhere to what has been clinically proven to be an effective way to deliver care. And then also, as we've seen in a couple presentations this morning, phone usage is kind of blossoming throughout India. There was a paper an article in the newspaper this morning that there are more cell phones in India than toilets in India, where people have more access to a cell phone than they do to a toilet, which is kind of an amazing statistic when you think about it. And then kind of what is even more amazing is what a cell phone like this today is capable of doing. There's a lot of amazing EMRs and EHRs that we've seen being presented today. And what's amazing is the computing power of this little device is able to do very similar things, not necessarily to the scale that we've been seeing, but at least as an outreach. In the hands of an ASHA, something like this can be a very, very powerful tool. And so that's where what we have worked on. We worked on a program or a project called ComCare, and it's basically a case management tool that runs on a phone exactly like this, or it runs on a more advanced phone like an Android, or it can run on a tablet. But most of ASHAs, the ASHAs that are running around aren't going to have tablets, but they're much more likely to have a low-end phone like this that is much less expensive and is incredibly powerful. And so what we provide is a case management tool. So using a phone like this, you can go, the ASHA can carry it on their home visit instead of or in addition to flipbooks that they typically carry. And they can use it to record information, to give counseling messages, to increase their ability to follow a given protocol and provide them with decision support. So it all boils down to a few basic forms that are kind of linked in an intricate way. In a form you can enter anything, so be it kind of text or dates, numbers, multiple choice, single choice. It all revolves kind of around the patient case. So if an OSHA was visiting me because I'm sick, they would just fill out my details in a registration form, submit it. Everything gets submitted from a cell phone via the cell phone network to a server that houses all of the information. And then as she comes back and visits me more often during each of the follow-up visits, she's able to fill out different forms along the continuum of care. So maybe if I was a pregnant mother, for instance, she could fill out a pregnancy form for me, or a postnatal form for me, or keep track of the immunizations of my child and submit this, all revolving around the case structure that is centered around me, to a central server to track all that information. And once you have all of that information stored in one place, it's also amazing what you're able to do with it today. So this is an example of what we're able to put on the phone. We can put images and video, audio. So this helps low literate OSHAs who maybe aren't able to read what would be on the phone to help them to do their job. So it'll read the question for them, for instance. I don't know if you'll be able to hear this. Not in this presentation. But so it reads in Hindi, an audio recording that reads out the question, and you can put a counseling message behind that question. So if this is an IFA tablet question, for instance, to not only just say, are you taking your IFA tablets, yes, no, but this is the importance of taking IFA tablets. And so it acts as a tool to support the OSHA giving a counseling message, which is useful for especially sensitive subjects that they're teaching on, like family planning. Often they'll skip over those parts that they're supposed to in their job to talk about, but don't necessarily do because it's sensitive and challenging for them. Here are a few features of what the platform is capable of, but I'm going to skip through this and kind of talk a little bit more about the overall strategy. So you're able to collect a lot of information via an OSHA or an outreach worker, and I'm going to start to migrate from OSHA and onboarding to outreach worker to tie it back in with kind of the theme that was e-transformation of hospitals. So starting with the far bottom right, the OSHA collects information and submits it to a server. The supervisor is then able to see the data that is also submitted on the server, so they can see kind of work management. So they can see which of their OSHAs are collecting forms, how long a home visit takes, for instance. They can see high performers and low performers and know how to better manage the low performers. They're also able to see kind of the cases, so they can see if this one particular case needs more attention, then they can direct the OSHA to give that more attention based on the reports that are coming out of the server. Then also you can create actionable data that can send SMSs back to the OSHA or back to the supervisor to give them reminders about upcoming care. OSHA Manju, you've got a visit to take care of in the next 3 days, this is a reminder. Or you can send an SMS to the supervisor that says, OSHA Manju hasn't visited 5 people that all have overdue visits, so can you please figure out what's happening? To kind of reinforce the existing healthcare hierarchy that already exists. So now I want to try and tie it back into what we've been talking about here a lot today. And this is adding one key piece, and that's a clinic or a hospital. If you're able to have a system that is collecting similar type data, talk to the same server, you can now have almost a cycle from the patient coming in and getting care at a clinic or a facility, and recording that information in an EHR or an EMR, and then having the ability to follow up with that patient afterwards. So we come back to this situation where I visit you for treatment, I get great treatment, I need a follow-up and I go home. Now we're able to provide the last piece that kind of links it all together. So an outreach worker or an OSHA or an Anganwadi worker or a link worker, because in urban areas there's a health kind of workforce that's out there already in India. You can utilize a lot of these outreach workers of health facilities to give follow-up care at the home or the point of care in a home, for instance, instead of necessarily at a hospital. So if I go home because I was sick and the medicines don't work, in 2 weeks we can send a message to an OSHA that works in the catchment area that I live in, and she could get a message that says, Matt was really sick, he had malaria, he was supposed to come back for a follow-up visit a week later, he never came back. Here's his address, here's his phone number, here's the medicine he was prescribed, go see how he's doing. She can show up at my door and fill out information on my phone saying, I visited Matt. He didn't come back to the health facility because the medicine worked. He felt all better. He didn't feel the need to go back because he was healthy, which I think is a very common kind of thought process in which people don't go back to a health facility because they don't feel sick anymore. Or the phone could guide an ASHA through a thought process of the decision support of, oh, he still has these symptoms, and going through kind of a logic tree, like an IMCI protocol, for instance. He could say, yes, you need to refer this person back to the clinic, or no, this person is fine, visit them in 2 weeks to see if they're still fine. So you can kind of complete the cycle here between treatment at the facility, client follow-up, and client referral to the facility. So here what we do is we work a lot in the bottom right corner. So far in India, we've got a lot of different projects that involve ASHAs and Anganwadi workers using phones and connecting them to a server. The reason I put in the bottom left the CIDRS logo, that's the Center for Infectious Disease Research in Zambia, is because this isn't a thought experiment. We're actually doing this, and we're not doing this in India yet, but we've got a project running in Zambia where we've got in rural clinics powered by solar power, because it's Zambia, it's a little less developed. We've got a kind of an EMR type system. It's definitely not a heavyweight EMR, but it's recording primary care information, linking it to a server, and then sending that information to the phone of the CHW running around. And we're currently scaling into 50 rural clinics with 300 community health workers that are kind of all working in the catchment area of those clinics. So let me keep it brief because I know there's a time constraint. And so I just want to conclude and say thank you very much, and that there's a potential to go to the last mile of healthcare using information technology in just kind of new and innovative ways outside of the kind of the standard ways that have been used so far. So thank you very much.